Thank you for joining me in this session to discuss advanced clinical practice roles in the NHS, panacea or challenge for workforce problems. I am presenting on behalf of the team, Francesca Taylor and Mary Halter from the Centre for Health and Social Care Research, Kingston University and St George's University of London. In this session, I will outline the policy issues, our study, its theoretical framing, and invite comment. Before I start, I wish to acknowledge and thank all those who gave their time to the study and note the disclaimer that all views expressed here are of the researchers and not necessarily the funders, Health Education England, London. HEE is an arm's length body of the Department of Health and Social Care England. It's responsible for education, training and workforce development in the health sector. All healthcare systems are challenged by what Bodheimer and Sinsky have described as the quadruple aims, which are listed on the slide. Internationally, there have been shortages and/or maldistribution of health professionals, including doctors. One solution to the shortage of doctors has been to develop what has been described by the World Health Organization as mid-level roles, such as nurse practitioners, clinical assistants and physician assistants. The National Health Service in England is a tax-funded health system available free to all at the point of delivery. The NHS has and is predicted to continue to have significant medical and nursing shortages. National policy has been promoting advanced clinical practice roles for nurses, midwives, allied health professionals and health scientists. The policy aim is to improve patient experience, service productivity, and also the work and career experiences of staff. ACP practice is defined as delivered by experienced, registered health and care practitioners. It is a level of practice characterised by a high degree of autonomy and complex decision-making. The interim NHS People Plan allocated significant monies to scale up the education of ACPs, and a snapshot census was commissioned due to a report later in 2020. The study I am presenting at this conference was commissioned to provide a more in-depth consideration of the factors influencing the development of these roles. I undertook a qualitative study addressing the questions on the slide as to the factors which support or inhibit the development and sustainability of such roles. We undertook semi-structured interviews with 20 participants in 2019. Participants were senior managers, clinicians, and those with lead roles for workforce development in acute, community, and emergency service NHS trusts in South Greater London. Trusts are the name given to NHS organisations. Thematic analysis was undertaken of the data, and emerging findings were presented to a pan-London expert group to confirm credibility. We framed the study within two sets of theories. Greenhalgh et al.'s model, illustrated here, in which context, knowledge purveyors, user system, resource system, and change agency interact to facilitate or hinder the adoption and diffusion of innovation. The second, Abbott's theory of the system of professions, in which there is a dynamic process of jostling relationships between health professions for jurisdiction, control, and rewards. So what did we find? Firstly, the number of actual ACP posts were reported as a very small percentage of staff, often in single services. Most ACP posts were very new, although in some services, such as the emergency departments and physiotherapist-led musculoskeletal services, there was a 10+ year history of development. These types of ACP posts can be traced back to the workforce initiatives of the NHS Modernisation Agency in the early 2000s, which were developed in the face of a previous crisis shortage of doctors and nurses. While some participants reported that their organisation had a good understanding of the numbers and types of ACP roles, others reported their organisation was just starting to look at this information or look at these roles. Some organisations had siloed development, as in this quote, but a few described a more comprehensive strategy at an organisational level. We identified 4 main influencing factors in the development of the ACP posts. First, the strategic response to medical shortages, as in this quote. Second, specific new finance for ACP posts provided by commissioners, and this was new monies to fulfil either NHS long-term policy commitments in primary care, or new monies for local pilots of integrated care services deploying ACPs, or new monies for pilots for training ACPs. The third factor was the desire to retain experienced staff through new career opportunities, and the last was more ad hoc, expanded roles developed around individuals and then integrated. 2 key factors were reported as enablers in developing and sustaining ACP roles: finance for substantive posts and evidence of value. The quotation shows how the evidence of value allowed the business cases to be made for substantive funding for the ACP posts. However, no participants were able to provide written or published evaluation reports of ACP roles in their services or evidence of public and patient views on new ACP roles. At the same time as pointing to the hard enablers of ACP roles, i.e. finance and evidence of value, some participants in a minority of organisations reported other enabling structural elements which will be familiar to those of you aware of change management strategies. These included having visible organisational commitment through workforce strategies, for example, having senior executive members championing the ACP roles, such as executive directors or clinical directors, having a senior member of staff with a remit to support the development of the roles and share good practice. Inhibiting factors were reported as more than the converse of the enabling factors. Yes, lack of finance and resources was a reported significant inhibiting factor, but participants were able to point to more other influential inhibiting factors. They reported confusion and lack of knowledge about the ACP role. They talked about unanswered questions, for example, about lack of clarity on governance. Some reported that the professional groups, such as nursing and AHPs, were actually split in their views as to whether ACP roles should be supported, with unanswered questions as to what the career route in was and the continuing career route, and whether the pay reflected the level of responsibility of the work. Participants also reported that senior doctors were unsupportive, describing this as ranging from nervousness through to active resistance to ACP posts. The source of these unsupportive attitudes was said to come from disagreeing the concept of ACP roles as undertaking some of the medical role, lack of evidence of the safety and efficiency of the ACP roles, perceived failure to resource the medical time needed to support this training and ongoing supervision of ACP roles, which was described as substantial. And finally, in the absence of new finance, the irreversible conversion of medical staff budgets, for example, of a long-term consultant vacancy to create the new ACP posts. So, turning back to our framing theories, the external context, in this case the NHS long-term policy, and the resource system, in this case the local and national commissioners of services, were having some influence on promoting this workforce innovation of ACP posts in user systems, where there was additional or new monies. The user system factors appeared more influential where the innovation of ACPs was to be resourced from within internal budgets, which in most NHS organisations are siloed by service and by professional groups. At this point, the jostling between some professional groups becomes evident for resources, jurisdiction and posts. And change management techniques have been and will be needed to be deployed. But the knowledge purveyors will require robust evidence, which is not currently available. So to conclude, will ACP posts be the panacea or a challenge for workforce problems? The theoretical framing suggests both a solution but also a challenge. While the policy agenda is to promote ACP roles, there is limited understanding, confusion and nervousness at the operational level. Development scenarios that introduce new monies for such roles will reduce some of the inhibiting factors. However, where the introduction of ACP roles requires funding to move from one part of a service to another and potentially from one staff group to another, the growth of these roles is likely to be contested. Finally, the paucity of publicly available evidence on the effectiveness of ACP roles and of public perceptions requires urgent attention and research. Thank you for listening. Comments, clarifications and observations are welcome in the comments below the video. We will read and respond, or you can email me v.drennan@sgul.kingston.ac.uk. Have a good conference.